Looking at the phenotypic presentation, I think that bipolar II disorder is much closer to MDD than to bipolar I, because hopefully everyone here has been hypomanic. When you are in love, when you travel, when you basically have a good time. So when does that become bipolar I-ish type? So I find it really hard to differentiate. And we treat bipolar II depression obviously like depression. The question is only, are those patients at a higher risk of flipping? So in that sense, there is this continuity, and it's difficult to differentiate. But all models are wrong. Some are useful. Ultimately, we don't treat diagnoses. We treat symptoms, and we try to guard against too much mania with certain treatments for bipolar II.
I think these distinctions are kind of artificial. Stahl used to say, bipolar I, bipolar II, there's probably bipolar 99. I don't know, Roger, what do you think? You're an expert on
Well, I think, first of all, bipolar II, I always put a little call out. David Dunner over in Seattle, psychiatrist, coined the word or the phrase bipolar II disorder way back in 1976.
That's right.
So bipolar II disorder, in many ways, was it's always been sort of a poor cousin, so to speak, to bipolar I, and always was sort of an afterthought. And 1976 was when it first came into our vernacular in psychiatry. I agree with what you said, Christoph. When you look at the genetic architecture, if you begin with that, studies, which are far from complete and far from fully informative, but that aside, the genetic architecture of bipolar II disorder is a bit closer to MDD than it is to bipolar I. Bipolar I, especially with psychosis, is a little closer to schizophrenia. And what's interesting is that I think, again, this is the heterogeneity question. At some point, the two organisms become very distinct. We know that bipolar II disorder breeds bipolar II. There's been lots of work on that. Bipolar I breeds bipolar I. That's been well established. But there are, in fact, it's fuzzy at the boundary, and so on and so forth. Part of the hampering effect on the science of this is frankly, the difficulty in delineating bipolar II.
Absolutely.
And because that phenotype has a relatively low inter-observer agreement, it really belies our ability to really characterize these neurobiologic differences to the extent that we would like. But I would say they are different animals, because if I had a patient with bipolar I disorder who was stable and episodic, and now they're in my office with bipolar depression, they don't have rapid cycling, never say never, but I almost never would give them an antidepressant as monotherapy. Almost never. In bipolar II disorder, if they are stable, episodic, not rapid cycling, no mixed features, I have and I would consider an antidepressant as monotherapy. In some cases, not my first go-to, I would consider an atypical, a lithium, or lamotrigine, but the evidence is clear that there are a subgroup of bipolar II patients who are safely and effectively treated, but I would do bipolar I.
Joe Goldberg agrees with you. I am not that much of a cowboy. I'm just not taking that risk, but that's all right.